Corneal degenerative processes can occur due to the wear and tear that occurs at the level of cornea. And this wear and tear can be caused due to the inflammatory reactions that occur at different histological layers of the cornea, or even it can be any trauma that is subjected to this corneal epithelium over here. Now, this wear and tear and this traumatization or these infectious processes can occur at different levels in the cornea. It can be the epithelium that is involved, or either it can be the Bowman's membrane that is involved. Now, when we just recall the applied anatomical and histological features of the cornea, we know that there is an epithelium, which is basically a stratified squamous type of epithelium when we talk or when we have that basic background knowledge regarding cornea. And then we have the Bowman's membrane that is then becoming continuous with the stromal layer of the cornea. Finally, this stromal layer is resting upon the Descemet's layer, that is the major basic protective membrane of the cornea. So any of these layers can be involved in all of these degenerative processes that we are going to talk about today. We know that there are a lot of systemic infections and systemic conditions that can even manifest as a degenerative process occurring at the corneal level. It can be even the infections and inflammations of the primary level occurring only at the cornea, or even it can be the secondary infections from the neighboring structures that can invade the corneal epithelium as well and involve this epithelium. And finally, they're again going to result in the corneal degenerative processes. So having that clear in your mind that we have all of these processes contributing towards corneal degeneration over here is very important. Now, when we come across these corneal degenerations in our outpatient departments, we know that we have this specific clinical classification as well. Depending upon the cornea or the level or the location of the cornea that is involved, it can be even the peripheral structures of the cornea that are involved. And usually when we use or when we have these patients who have the corneal periphery involved, that is basically regarded as the limbal area to be involved. Limbus is basically the terminology when we say that it is in conjunction with the conjunctiva as well. And usually the degenerative processes are also accompanying the conjunctival degenerative processes over here in these kind of cases. So you will come across all of these anatomical features and anatomical classification as well when you come across these patients. So you should know how to classify these cases, because whenever you're going to have these patients, they're going to suffer from visual impairment or a decrease in the visual acuity, as well as there is going to be a foreign body sensation in the eye, the phenomena of redness, increased lacrimation, increased itchiness is usually subjected to these patients. So these would be the common complaints that the patient would come up to you with. And then the points in the history are going to highlight what was the causative factor towards the development of this specific kind of corneal degeneration that we are dealing with over here. Mainly and specifically, we have these major groups of classifications over here. First of all, we can classify these patients depending upon the location of the corneal ulcerations. So even it can be the axial corneal degeneration. It can be due to the fatty degeneration. Usually it can be due to the hyaline degeneration. And we have amyloidosis as well in this list. We have the calcific degeneration, which is also included in the list of axial corneal degeneration. So you have to note these anatomical features while we are just examining the cornea of a patient. either through the direct illumination technique or either using the indirect illumination techniques in these patients, making the patient sit on a slit lamp and you're sitting across the patient and looking at the patient's positive findings in the cornea is basically regarded as the direct illumination technique. So we can use this technique to examine and look for the positive findings in the cornea, identify whether this particular patient is suffering from a hyaline degeneration or a calcific degeneration, depending upon the systemic conditions in the patient. So the investigations and the baselines are very important when we have these patients at our hand. For instance, we have a fatty degeneration in someone's eye and we have diagnosed a person to be suffering from fatty degeneration. So this process can be of a primary type or either it can be of a secondary type. So when we say it is a primary fatty degenerative process going on in a cornea, that means that this particular patient is not suffering from any kind of hyperlipidemic condition or any increased levels of cholesterols in his or her blood levels. On the other hand, if he or she is suffering from a secondary sort of fatty degeneration, that is basically regarding the fact that this particular patient is suffering from a systemic process or a systemic pathology, for instance, hyperlipidemias or hypercholesterolemias that can be detected on investigations, and obviously this is leading to this kind of fatty degenerative process in his or her cornea. Then we have the hyaline degenerative processes, and these are usually caused due to the long-standing keratitis in these patients. So chronic keratitis, if it is positive in the history of a patient that he or she has been suffering from a long-standing keratitis due to any of the causes, it can be bacterial, fungal, protozoal, keratitic conditions that can occur in the patient. That can even lead to this kind of hyaline deposits in the corneal epithelium. Usually all of this process is taking place at the level of the Bowman's membrane. So this is the whole process of the amyloid, of the hyaline degeneration. Amyloidosis, as the name is indicating, it's obviously the deposition of the amyloids at the level of the Bowman's membrane. And then finally, we have the calcific degeneration that are usually resulting due to the conditions of flictanular keratitis, or either it can be the rosacea keratitis that is usually leading to this kind of a condition of the calcium deposits at the level of the Bowman's membrane. So this is the whole etiological classification. And then finally, we have this salzmann's nodular degeneration. Again, it can be due to the trachoma that the patient is suffering from. Again, I would like to emphasize this fact over here. As you can see, the systemic illnesses are finally manifesting as the ocular diseases in a patient. Either it can be the corneal degenerative processes or dystrophies, or even the conjunctiva can be affected in these patients. Whatever the case is, the baseline investigations and the complete and the detailed history taking is very important over here, and that is going to highlight the particular pathology behind that corneal degeneration that the patient is suffering from. And obviously, the treatment and the management plan would also encompass to deal with that underlying pathology that the patient is suffering from. Whatever the cause is, you have to, first of all, treat the underlying cause to get better results in these patients, of course. And then finally, we have the peripheral degenerations over here. So we have Arcus senilis, and Arcus senilis is basically the age-related degenerative processes that are occurring in the patient. So we have another variety which is known as Arcus juvenalis. So as the name is indicating, it is occurring in the younger patients on the other hand. And it's another variant due to the systemic conditions in the patient. There is a fatty deposit, and that is basically presenting just similar. The clinical presentation or the clinical picture is just similar to this Arcus senilis. And again, the patient would be complaining of the same conditions We have the Watts white limbal girdle. Again, it is usually an age-related process that you would see in these patients. So then finally, we have the Hessel-Henle bodies that even you can observe. These are the grayish white cloudy patches that you can observe in these patients, and that are again going to basically highlight the fact that the patient is suffering from some sort of a peripheral degeneration in this regard. Then finally, we have the terrene marginal degeneration. It is again, as you can see, that we are basically focusing on the peripheral degeneration, and there are different pathologies or etiological factors again predisposing this particular patient towards the development of peripheral degeneration of the cornea. We have the Murren's ulcers. It is of an infective cause, of course. And then we have the pellucid marginal degeneration. So these are some of the variants of the peripheral degenerations that we'll be discussing quite briefly and summarizing the clinical features further on. And finally, we have the furrow degeneration. As the name is indicating, the pathological features are that it is basically involving the periphery of the cornea. The limbus is involved mostly. And the furrow is basically the shape of the degeneration that is given over here due to the underlying pathology. That is basically giving the major terminology of a furrow degeneration in these patients. We'd be looking at the clinical pictures alongside, and depending upon the etiology, we classify the degenerations. Either they are related to the aging process. So if they are related to the aging process, it is usually the Arcus senilis. Then the patient can suffer from the Watts white limbal girdle, or either it can be the Hessel-Henle bodies that usually appear. And usually all of these conditions appear simultaneously or alongside coupling. You would be also observing an Arcus senilis, and upon a direct illumination technique, you can observe these Hessel-Henle bodies in the aged individuals. Usually, the 4th to the 6th decade of life is manifesting these conditions of the corneal degenerations in these patients. Then we have a mosaic pattern of degeneration also observed alongside with the age-related processes. The pathological degenerations can be due to the fatty degeneration. Again, it can be the hypercholesterolemia, hyperuricemia, or hyperlipidemic conditions. Even the chronic renal failures usually present with pathological kind of degenerative processes. Amyloidosis is one of the systemic conditions that is again going to manifest, and calcific degenerations is again the deposition of the calcium at the corneal epithelial level. And then we have the salzmann's nodular degeneration, which is usually related to the condition of trachoma in the individual. Either it is the flectanular keratitis or the rosacea keratitis that is noted down in these individuals. So it's basically a quite brief summarization of the corneal degenerative processes. And it's again very easy to remember that how can you clinically classify these patients depending upon the location of the corneal degeneration, and on the other hand, how can you classify depending upon the etiological or the pathological processes that are going on. Again, this is very easy, and again, it's very easy to document these cases when you know these classifications. You have a list of differentials in your mind whenever you are seeing these patients of corneal degenerations. You would have these lists in your mind, and you can list them down and then obviously perform the baseline investigations and then finally get the definitive diagnosis depending upon the underlying pathology in these patients of corneal degenerative processes. Furrow degeneration, we saw that it's basically a kind of peripheral degeneration, and there is also a spheroidal kind of degeneration, pellucid marginal degeneration, and terrene marginal degenerations. There is an underlying definitive pathology that we're dealing with whenever we have these patients of these particular kind of distinctive degenerative processes. You would usually come across these patients of Arcus senilis when you are conducting an outpatient department. So usually the patients, almost 30% of the patients age grouped between 40 to 60 years of age group is usually affected by this condition, which is known as Arcus senilis over here. Almost patients who are reaching about the age of 80 years, they would definitely come up to you with this kind of a presentation of Arcus senilis over here. So this is the kind of presentation that they have when you're looking at them. This whitish deposits or this whitish circle that you can observe over here, this ring-like structure observed at the limbus is basically known as the Arcus senilis over here. And this is again an age-related process. The fatty deposition is basically the underlying pathology over here. This fatty deposition is occurring at the level of the Bowman's capsule. On the other hand, as I've already mentioned, there is a condition which is known as Arcus juvenalis. So if you see this kind of a picture in a patient who is almost in his or her 20s or 30s, that would be basically regarded as Arcus juvenalis, and that has these particular systemic findings. Usually these patients would be suffering from a condition of hyperlipidemia or even hypercholesterolemia. So running the diagnostic tests over here is again very important in these patients. So the age-related corneal degenerations, we know that we have basically a lucid interval of watts in these patients. As you can see and you can observe in all of these patients that we have these techniques of examining these patients. This is basically regarded as the lucid interval of watts. So this patient would basically be having a ring-like structure at the limbus, and then there would be a furrow that would be observed or a depression that is observed that would be regarded as the lucid interval of watts in these patients. This is a particular finding that we would particularly appreciate in these patients of Arcus senilis over here. So it can be even inferiorly located, or either it can involve the superior limbus in these patients, depending upon the different kind of locations that we observe in these patients. Now, usually these patients who are suffering from these age-related problems are lying in their 4th, 5th, or 6th decade of life. This is the probable period in their lifetime that they're suffering from this kind of a condition, such as Arcus senilis, or even it can be this another variant of Arcus senilis, which is termed as the Watts white limbal girdle over here. So the findings are quite similar. When we are examining these patients, we would just observe the fact that there is a ring that is located at the periphery of the cornea, just near to the limbus. Limbus, as we know, it's the junction of the cornea with the conjunctiva. So this limbal girdle, or its whitish discoloration, this is sometimes notified as or termed as the Watts white limbal girdle over here, and it appears as such. So this chalky white appearance that is given to the cornea near the limbus, that is regarded as the Watts white limbal girdle. The appearance of these limbal girdles, it can be, again, this is an age-related process that is going on with these patients. These degenerative processes are going on. It's neither any dystrophy or any abnormality with the corneal cells. It is not any other pathology, any other systemic pathology that is going on with these patients. So you would observe that even in the absence of any other underlying pathology, these patients are having this haziness of cornea that they are suffering from, and this condition would be regarded as the Watts white limbal girdle. The probable signs and symptoms that these patients would be suffering from are quite conspicuous. You won't be noting down any foreign body sensations or even any tearing phenomena in these patients. Neither would be any redness of the conjunctiva noted down in these patients. Obviously, there would be a decrease in the visual acuity, and that is again not related to this haziness of cornea. It's due to the any cataract formation if they're suffering from. So again, if you have these patients at your hand and these old age patients are suffering from a decrease in the visual acuity, you would note down that this patient has a positive warts, white chalky appearance, but still you would note down whether this patient is suffering from any cataract formation or not. It can be an immature cataract, which is making a decrease in the visual acuity quite positive in these patients. This white cataract can even then continue into a glaucomatous condition in the patients, and it can be an emergency condition. So knowing the non-emergency conditions and identifying the emergent conditions is again very important in these old age patients, because having to deal with these geriatric patients is again very tricky. Usually they are suffering from any either they are the diagnosed cases of amyloidosis. So if they are suffering from any other pathology, any other variant condition, you have to document that this particular patient is suffering from this particular kind of a pathology. For instance, the patient might be suffering from hypercholesterolemia or even hyperlipidemia. You have to note down these conditions, and still you have to note down in the ocular examination whether the patient is suffering from any long-standing keratitis or what are the positive signs and symptoms of any infectious state that the patient might be suffering from. So again, these patients or these problems that are age-related are quite conspicuous and sometimes quite tricky to diagnose. Another age-related corneal degeneration is the Hassel-Henle bodies. So these are basically giving out the dotty appearance to the corneal epithelium. Usually they are the result of the hyaline deposition at the Bowman's membrane. And if there is a peripheral degeneration and if they're located at the periphery, this is known as a positive Guttata finding. And it is basically linked to this Hassel-Henle body. So when you'll be examining the whole of the cornea, you would note down that they have this whitish, dotty appearance that is noted down in these patients of all of these age-related changes that are occurring at the level of the corneal epithelium. So these are the positive findings that you would look for. And finally, we have the pathological corneal degenerations. Once we are done with the age-related corneal degenerations, you should know that there is another group of degenerations which is related to the systemic pathologies. The most notorious of this is the lipoid keratopathy. So if it is the lipid deposition, which can occur in states of hyperlipidemia, hypercholesterolemia, it can be the chronic renal failure even, which is resulting in these states of lipid keratopathy in these patients. On one hand, it can be a primary condition. When we say it is a primary condition, it means that the patient is not at all suffering from any sort of any other pathology. His lipids levels and his cholesterol levels are quite normal. When we run the baseline examinations, for example, the blood CPs, the ESRs, the renal functions, liver function tests, they all appear to be normal in these patients of primary lipid keratopathy, but still they are suffering from this lipid deposition at the level of the Bowman's membrane. What is triggering this? The triggering factor over here is the irritation. It can be the environmental conditions that are quite vicious and that are basically making the corneal epithelium more prone to the traumatization and towards the lipid deposition. Even the ultraviolet rays, in some people, the corneal epithelium is sensitive enough when it is exposed to the ultraviolet rays. They usually suffer from this kind of lipid keratopathy. So this can be one of the conditions over here. And on the other hand, we see that we have the secondary lipoid keratopathy. Secondary, as the name is indicating, obviously these kind of patients would be suffering from some sort of a systemic condition. as we've already mentioned, and that is in turn resulting in this lipid deposition which is occurring at the level of the Bowman's layer. Then finally, we have another variant which is known as the hyaline degeneration. Now, this hyaline degeneration is basically regarding the hyaline deposits that can take place, again at the level of the Bowman's layer. The clinical signs and the clinical presentations would be quite conspicuous: decrease in the visual acuity, foreign body sensations, irritations would be noted down by the patient. And usually when you would take a complete detailed history from these patients, they would usually come up with the positive history of a long-standing keratitis. So these would be the particular features over here. As you can observe, the hyaline deposits can even be observed on the histology when it is taken. We can take or we can observe these histological findings over here. And that is basically relating to the fact that we would be basically observing the whole layers of the cornea, the whole histological features. Apart from the epithelium, we'd be observing the stromal deposition. So this is the end of the epithelium, and this is basically the deposition. This is the stromal layer, which is involving or where the hyaline deposition is taking place in these patients. So this would be the basic pathological process in these patients of hyaline degeneration. They would be giving a positive history of a long-standing keratitis in these patients, or either it can be a trachomatis pannus or even a positive history of glaucoma is observed. Glaucoma is basically a condition in which there is an increased intraocular pressure, and that is again going to be subjoined or conjoined with this kind of a hyaline degeneration, which is noted down in the glaucomatous patients. So all of these features are again very important whenever we are taking the history from the patient and noting down the positive findings that can basically make the definitive diagnosis of hyaline degeneration positive in these patients. Then finally, we have the amyloid degeneration as one of the causative factors. The positive findings again over here would be the haziness that is observed in the cornea, the whitish degenerative processes, the whitish hue that is given out, the cloudiness to the cornea. The patient would complain of a decrease in the visual acuity, of course, and when we're going to run the baseline investigations in these patients, that would basically reveal that the patient is suffering from amyloidosis, or either the patient would be a diagnosed case of amyloidosis and can come up or show up in the outpatient department, and you should know how to relate these two conditions, the haziness of the cornea with the pre-existing condition of amyloidosis in these patients. So again, you would basically focus on dealing or treating the underlying pathology in these patients, and that can improve the overall outcome and the prognostic factors in these patients. Calcific degeneration is again very important, and sometimes you can come across this kind of a band-shaped keratopathy in these patients. As you can observe, this is a band-shaped keratopathy. This is usually the kind of a band that is formed on the cornea. It is not involving the limbus particularly, as you saw in all of the other pathologies. This band kind of a keratopathy is usually observed in the calcific kind of degenerative processes. This process is again taking place at the level of the Bowman's membrane. So you have to note that down, the level at which this calcium deposits are taking place. Any conditions of hypercalcemia can predispose the patient towards the development of this kind of a condition. The treatment guideline or the management guideline, as I'm already emphasizing upon, will be to treat the underlying cause in these patients and then finally come to the keratoplasty in these patients. Because before performing the keratoplasty, if you treat the underlying cause, there would be the better outcomes, and the remissions and the recurrences can be prohibited in these patients of the band keratopathy or the corneal degenerations, which are of either the calcific causes or the amyloidosis, or even the hyaline degenerative processes in these patients. So this would be the what are the causes of the band-shaped keratopathy? In adults, usually the causative factor would be the chronic uveitis in these patients. In children, you can come across different pathologies. It can be even the Still's disease or either the phthisis bulbi. So these are some of the congenital conditions that the patient or the child has been born with. So, or the chronic glaucoma. So these can be the conditions in the children that can predispose the patient, and he or she will develop the band-shaped keratopathy on long terms, chronic keratitis due to any of the congenital conditions, and even the ocular trauma can result in this kind of a band keratopathy in these patients. Obviously, the signs and symptoms would be a decrease in the visual acuity, haziness of the cornea would be seen. Then we have, on the other hand, the age-related keratopathies in these patients. And finally, we have the familial, that is a genetic predisposition to the development of calcific degeneration, or either a lot of metabolic conditions can even result in this band-shaped keratopathy in these patients. What can be the metabolic conditions? Obviously, it can be hypercalcemia or it can be hyperphosphatemia in these patients. That is basically the increased in phosphate levels in the blood, and hyperuricemia, an increase in the uric acid levels. And then we have the chronic renal failure if the patient is suffering from. So all of these metabolic conditions are going to finally give the final picture of a calcific degeneration that is occurring at the corneal epithelium. Now, the particular clinical features that the patient would come up with are the band-shaped opacity in the interpalpebral zone. Then, if you would be looking at the patient quite noticeably, you're going to see that there is a clear interval between the ends of the band and the limbus. It basically begins at the periphery and the opacity beneath the epithelium, and there are basically the transparent clefts, as even you can observe over here. This is not a full-fledged hazy band as you can observe over here. There are the transparent clefts in between, and they are quite particularly seen in these patients of calcific depositions. So as we already know that there are a lot of multiple factors towards the predisposition of this calcific degeneration over here, we should know that the management of these patients is the supportive therapy that is usually given to these patients, and then obviously treating the underlying cause in these patients. But the mainstream for the treatment would consist of the chelation that can be observed. The corneal epithelium is scrapped. This is basically a procedure for keratoplasty that is being observed for these patients. A 0.01 molar solution of EDTA is applied, and then we basically pad and bandage for 2 to 3 days. This is the whole procedure for the chelation. Whenever we have these patients of calcific degeneration, this is kind of a keratoplasty that is performed for these patients, and this can result in an improved vision in these patients, and quite positive results are seen in these patients. Then obviously we have another sorts of treatments, for example, the phototherapeutic keratectomy. Now the steps for this kind of a phototherapeutic procedure are, we have the chronic stria, and then we have the phototherapeutic keratectomy done. We have the lasers and the diodes that are basically applied for this purpose, and the treatment is basically depending upon the epifluorescence technique that is done, and that is basically giving way or making a window into that calcific deposition over here. As you can observe, this grayish structure over here is mentioning the calcific deposition, and as you can see, after the PTK it is transformed and we have a clear cornea that is observed in these patients, and obviously it is going to result in a clear vision in these patients as well. Then after you basically treat the epithelium, there is a reepithelialization that will occur after some time. Then we have the keratoplasties, which are performed, and they are a more detailed kind of a procedure. If there is an extensive calcific deposition, obviously, that would include a detailed keratoplasty being advised for these patients. The other features or the other classifications for the corneal degenerations, they include the Salzmann's nodular degeneration. Now, this kind of a degenerative process is usually seen in patients of trachoma, or either it can be the flictanular keratitis. On the other hand, it can be the rosacea keratitis that these patients usually presents with this kind of a nodular degeneration in these patients. So this is the major etiological factors: flictanular keratitis, trachoma, or either the rosacea keratitis. Whatever the cause is, or whatever the underlying feature is, we'd be noting, or we'd be particularly focusing, if it is the trachoma and we have the etiological or pathological organism is the Treponema pallidum in these patients, then the treatment would be, or even the systemic treatment would involve to treat and isolate that organism, of course, in these patients. And that would basically result in the better outcomes or the better results in these patients. The clinical features of this kind of a condition are obviously discomfort and visual loss, because of course there is the cloudiness, the haziness, the patchiness of the cornea, and that is going to hinder the vision and resulting in this kind of a discomfort and visual loss as well. The treatments that we're going to give for these patients of Salzmann nodular degeneration would be obviously a kind of a keratoplasty detailing any kind of a damage or a corneal degenerative processes, even the cloudiness or the haziness can be covered by these kind of keratoplastic procedures done for these patients. Now we have the other corneal degenerative processes which also regard to be of the furrow degeneration. Now this kind of the degenerative processes, which include the pellucid, the furrow, or the terrien variety of the degenerations, are usually at the margins or are usually occurring at the limbus of the cornea. They're usually regarded as, when you look at these patients, you would observe this whitish ring that is observed in these patients, and that is basically quite diagnostic when you are labeling a person to be suffering from this kind of a degenerative process. Then we have a spheroidal variety. Now, what are the causative factors over here? It can be the vicious environment that is surrounding the patient. It can be the ultraviolet rays, the aging process of the individual himself or herself, or either any disease process that is ongoing in that particular patient whom we are dealing with. Usually these patients would present to you with this kind of an amber colored appearance in their cornea, and that is quite distinctive for these patients of spheroidal degeneration particularly. Now, the treatment for these kind of spheroidal degenerative processes basically include, again, the corneal transplantation that can be done. Now, these are the particular steps that would basically include any prosthetic cornea that is placed and that is replacing the original cornea of the patient, which went through a degenerative process and that caused haziness and cloudiness, and finally decreasing the visual acuity of that particular individual whom we are talking about. Then we have a pellucid kind of a marginal degeneration. Usually it is a thinning of the periphery of the lower cornea that is occurring. And this is the picture, or this is the clinical presentation of this kind of a pellucid marginal degeneration. It can be occurring at a lower extremity or either an upper extremity, or even involving the whole of the cornea in a lot of patients. Then finally, we have a terrain variety. Now, this terrain marginal degeneration is usually a unilateral phenomena. It is an asymptomatic kind of a condition that the patient is suffering from. This is a usual clinical picture that the patient would be giving you. The haziness and the cloudiness that is observed at the margins of the cornea is quite distinctive for these patients of terrain marginal degeneration. Now, the causative factors over here are quite idiopathic, but still it is a non-inflammatory kind of a condition. And again, it is resulting in this degenerative process that is occurring at the Bowman's capsule, and it is only relating to the margins. So these are the particular clinical findings over here in these patients. The treatment for these kind of terrain marginal degenerative processes is usually a corneal graft because the visual acuity is decreased to a level which cannot be improved unless this corneal graft is imposed for these patients, and only then these patients can have a better prognostic outcome. So this is again very important to diagnose and have a definitive diagnosis at your hand, and then finally get to the management plan and the treatment plan that can be given for these patients of terrain or either spheroidal, or it can be even the salzmann corneal degeneration. So in this lecture, basically we summarized the different underlying pathological conditions. Either it can be an irritative process, an aging process, or even the environmental conditions can contribute towards the corneal degenerative processes. Whatever the pathology may be, it is going to result in a decrease in the visual acuity. So treating these patients is the mainstay over here. So one should know how to get to a definitive diagnosis and then how to finally make a treatment plan for these patients to have a better outcome in these patients. So that is the end to this lecture. Thank you for watching sqadia.com.